Okay, we should be live. To anyone watching, happy Cinco de Mayo if you celebrate it. If not, happy Friday, because that's exciting in and of itself. We want to talk a little bit about prediabetes and type 2 diabetes and what Ancestralize has uncovered about the actual causal mechanisms, ways we can diagnose it, and most importantly, treatment. So we'll run through this stepwise and kind of share what the team has discovered.
Okay, so we're going to start off with just defining what prediabetes and diabetes are, specifically type 2 diabetes. So prediabetes is a state of high blood sugars, also known as hyperglycemia. This is caused by insulin resistance in the body, and it's often considered an at-risk state for the development or the progression to type 2 diabetes. Type 2 diabetes, on the other hand, it's a medical condition where the body, again, struggles to manage blood sugar levels. And again, it's due to insulin resistance and also impaired pancreatic function. With persistently high blood sugar levels over a long period of time, this becomes quite toxic and the person begins to experience a variety of symptoms and complications with damage all over.
And the damage is being primarily done by the hyperglycemia, right?
Yes.
Cool.
So in terms of frequency or prevalence in the population, we're looking at the prevalence in the US population, and you can see that prediabetes is actually quite prevalent. 1 in 3 people, or about 38% of the population, have prediabetes. Interestingly enough, up to 80% of them don't know that they have it, which again is quite worrying because the longer you have it and it's not being treated or being reversed, the likelihood that you're going to develop complications and it's going to progress into diabetes. In terms of prevalence of diabetes, specifically type 1 or type 2, about 37 million Americans have diabetes. That's 1 in every 11. And of that, about 90 to 95% have type 2 diabetes. So, I mean, that's a quite high figure, but it leaves room for some hope because it can be reversed once the right kind of treatment plan is started. And we'll talk more about that and lifestyle measures that we can use moving forward in the presentation. Again, there is a proportion of the population that is left undiagnosed, and about 3.4% of the US population has type 2 diabetes but is not diagnosed. And again, this can lead to complications and lots of issues in the future.
Yeah, so let's look a bit deeper into the mechanism. As Wafa said, there is pancreatic dysfunction that determines the progression towards prediabetes and diabetes. And the key for understanding the difference between only insulin resistance and actually developing the hyperglycemia, which comes with diabetes, is maybe found through understanding the glucagon and insulin ratio that changes, which is the function of the alpha cell and the beta cell that gets affected with the progression of the disease. So basically, on the ground of insulin resistance, we see an increase of systemic insulin resistance around the body. But at some point, though our bodies are very adaptable, the pancreas just can't keep up growing more insulin-producing tissue. And also the tissue itself becomes dysfunctional and insulin resistance itself. So we are looking deeply into the pancreas function, and we see that insulin, basically the insulin quantity goes relatively down, although it's higher than normal because the body is still trying to keep up with the sugar levels. But at the same time, the glucagon is too high and not controlled by insulin, especially in the liver, which makes it so that, especially after eating, the liver doesn't go into storage mode, and more glucose is just pushed through the system from overnutrition, stays in the blood because of the insulin resistance that is already there, and is just continuously elevated and toxic to the pancreas and to other tissue.
Thank you, Kaled. So for this slide, I'm going to talk about the vascular mechanisms underlying atherosclerosis, but also the kind of key impact it has on insulin resistance and type 2 diabetes. A lot of the complications, as we'll see in the next few slides, are related to the vascular issues that take place. And when we're looking at kind of why that happens, when we have the endothelium becomes dysfunctional for any reason, you get increased barrier disruption, increased vessel permeability, and then also expression of leukocyte adhesion molecules. One of the reasons we get this sort of endothelial cell damage is likely related to ingestion of certain foods, particularly plant seed oil. This can lead to oxidative stress within the vascular system, and then the oxidation of low density lipoproteins, making them smaller, denser, and in that way more damaging to the body. When these small and dense LDLs are present, your mononucleocytes, which are already found near the endothelium, differentiate into macrophages, and these begin to ingest these small dense LDLs. The macrophages become quite laden with them, and this triggers a sort of response across the body, creating inflammation locally, promoting local inflammation, platelet aggregation, and if this begins to, well, if this persists over a longer period of time, you might get plaques forming, and that can eventually grow and grow to either occlude the vessel, or if they rupture, they can create a full thrombosis and lead to many cardiovascular complications down the line. Now, this is sort of just a general mechanism for atherosclerosis, but in individuals who have insulin resistance, they also have reduced production of nitric oxide. Nitric oxide is really helpful for vasodilatation within the vascular tissue. And when it's reduced, you're going to have more narrowing of the blood vessels, more tissue ischemia, and again, kind of this risk for cardiovascular events. So that's really critical to keep in mind. The other part of it is, as people progress to type 2 diabetes, you're going to have more blood sugars and hyperglycemia, and this sort of creates changes in the properties of the vascular walls. The vascular endothelial cells become quite susceptible to hyperglycemia because the glucose can diffuse passively through the cell or plasma membrane into the cytoplasm. Here, there's more generation of these advanced glycogen end products. And again, they can be quite toxic to these cells, creating oxidative stress and vascular tissue damage. And again, just kind of contributing to these sort of vascular complications that we're going to come across with type 2 diabetes, especially as you have it over a longer period of time. The other part of it is hyperglycemia can stimulate something called MM9, which is the matrix metalloproteinase 9 secretion. And if a person already has plaques, this particular proteinase can then destabilize those plaques, so creating more plaque ruptures, and that could lead to more cardiovascular complications. And we'll talk more about this in the next few slides.
Thank you, Wafa. So it's been postulated that the mechanisms involved in inflammation and the innate immune system may underlie the pathological process of type 2 diabetes and other diseases related to the metabolic syndrome. Inflammation may be present in the individual for many years prior to an actual diagnosis of type 2 diabetes. If you watched our prior video on insulin resistance, similar to how inflammation is involved in insulin resistance via adipose tissue, these factors can also negatively impact the pancreas and impair its function, especially the beta cells, which produce insulin, like Kaled had mentioned earlier.
Okay. When we're looking at some of the main etiologies, lifestyle factors play the greatest role really for the development of type 2 diabetes, specifically diet and also sedentary behavior. When we look at the diet, the ultra-processed, very high in carb and low-protein diets have been implicated in metabolic diseases in general, type 2 diabetes, and also insulin resistance. And so stopping these particular diets and reversing them and using other like low carb diets, as we'll see, have been really helpful in kind of reversing type 2 diabetes. Sedentary lifestyle has also been implicated, and it can play a role. One thing that is often mentioned in textbooks or in other kind of written publications, that gestational diabetes may be a cause of type 2 diabetes, where in fact it's actually a related condition, and it shares a lot of the common features of insulin resistance, and that contributes to both type 2 diabetes and gestational diabetes. And so if a woman after giving birth continues to remain in a state of insulin resistance, she is likely to develop type 2 diabetes, but that's because the underlying pathophysiology, which is the insulin resistance, is persisting, rather than the disease itself causes the other disease. It's the underlying insulin resistance at play. In terms of symptoms of prediabetes and type 2 diabetes, these are really important just to think about and see if you or anyone you know has had them. With prediabetes, we said that up to 38% of the population have it, and about 80% aren't aware, mainly because prediabetes can be asymptomatic for a long period of time, and that's why it's often missed. However, for some people, they do have symptoms of long-standing insulin resistance. So you may notice that there is sort of darkening of the skin around the neck or the folds of the skin with acanthosis nigricans. You may see that you've got multiple skin tags, and these can kind of indicate that there is some underlying insulin resistance. For some people, they might start to develop some of the earlier symptoms of type 2 diabetes related to kind of high sugar, and we'll talk about that. Those main symptoms of type 2 diabetes are polydipsia, which is excessive thirst, feeling you always need to drink plenty of fluid, and even when you are drinking, your mouth is quite dry. You may have excessive urination or feeling that you're always hungry and you're always eating because of that. There's often tiredness and weight loss, but the weight loss is unintentional. So if you are already trying to lose weight, then it might be hard to notice that weight loss, but actually unintentional weight loss is a huge part of it. Slow wound healing, it can occur, and there may be vision changes, specifically the sort of blurred vision, or changes to acuity. So you're seeing a bit, you're not able to see as far as you could before. And then finally, one of the earlier symptoms of prediabetes is recurrent infections. And so that could be your urinary tract infection, it could be a thrush infection, skin infections. And not all people do end up being referred when they get lots of recurrent infections. They may then pick up that actually they have type 2 diabetes. And then that kind of leads us on to some of the more important long-term complications of long-standing type 2 diabetes. If someone is not diagnosed early and they have had the condition for many years, these features may actually be part of the presentation when they first go to their doctors and are checked out. We mentioned that type 2 diabetes affects the blood vessels, and so it could affect the large vessels, so your macrovascular system, or the smaller vessels, so your microvascular. Complications could be things related to atherosclerotic cardiovascular disease, and that could be a stroke or a heart attack or myocardial infarction, or peripheral vascular disease in the body. And I just want you to be aware that you may also have these with insulin resistance. So it's really with both conditions. And then in terms of microvascular, this is when the hyperglycemia impacts some of the tissues around the eyes and the kidneys, and also the neural system or your neurology. So you may feel sort of tingling or loss of sensation in your lower legs or also your hands. And then also you can get diabetic foot disease, which is when you get ulcers in your feet, and these small ulcers over time, if not treated, can become sort of skin infections, local bone infections, and again, if not treated over a long period of time, may result in amputation of toes or feet, or unfortunately sometimes legs as well.
So for the diagnosis of pre-diabetes, as established before, it's a precursor to type 2 diabetes that contains a high risk. Ranges of glucose parameters have been identified that would imply some state of intermediate hyperglycemia. Two parameters considered are the impaired fasting glucose and impaired glucose tolerance. So the ranges are listed here. If you have a fasting plasma glucose of 6.1 to 6.9 millimoles per liter, or a 2-hour plasma glucose of 7.8 to 11 millimoles per liter, which is part of the glucose tolerance test, you would be diagnosed with prediabetes according to the World Health Organization. As for the diagnosis of type 2 diabetes, as mentioned earlier, there are many symptoms associated with type 2 diabetes, such as polydipsia, polyuria, etc. So for an official diagnosis, you have to have some of those symptoms, plus different types of blood glucose tests. So there's a random plasma glucose concentration provided there, greater than or equal to 11.1 millimoles per liter, a fasting plasma glucose concentration greater than 7 millimoles per liter, or like for prediabetes, an oral glucose tolerance test, where your plasma glucose would remain at greater than 11.1 millimoles per liter. Another metric that's used is HbA1c, and an HbA1c value of greater than or equal to 6.5% is sort of recommended as a cutoff for diagnosing diabetes. But overall, you need a diagnosis to be part of two separate times. So the individual has to have abnormal tests on two separate occasions.
Yeah, to not be repetitive, we should look maybe again at the labs in view of the mechanism. So the oral glucose tolerance test, as mentioned by Jennifer, is one of the main ones, and it's actually the gold standard. And we mentioned the ranges, but we can also compare it to the others. Like, for example, it is more sensitive than fasting plasma glucose, and it can detect early stages of the diabetes, where still fasting plasma glucose might not be so elevated. So going back to the mechanism, this tells how much diabetes is more an issue of postprandial reaction of the pancreas and the body. As we said, it doesn't stop producing glucose from the liver. It doesn't detect the intake of food as well, because of insulin resistance that affects the liver and the pancreas. So we see that our tolerance to glucose is greatly affected, and the postprandial after food levels really go high. Of course, the fasting plasma glucose is still useful. It's less invasive, less sensitive, so more convenient, less expensive, and less. It still requires clinical lab, but it's easier than oral glucose tolerance tests, and it can tell us about, obviously by the name, the fasting level of glucose, which is very useful to see the level of insulin resistance. Next. Yeah, and then we're kind of going by less and less sensitive, so a random non-fasting plasma glucose is useful, but not as precise for general evaluation, screening, or just for sake of measuring for oneself. It's very handy, but it's not the main diagnostic one. It tells us, depending on the time in which it measures, what's the situation of the sugars. HbA1c, already mentioned by Jennifer, has low sensitivity, as we can see, high specificity compared to oral glucose tolerant test. It's more of a reflection of our over time exposure to glucose, but as mentioned, it's not so sensitive, and it might be erroneous. It doesn't really reflect the health of the pancreas and the glucose tolerance, because it might vary depending on the population and the diet followed and other elements. So yeah, that's it.
Yes, so piggybacking on what Kaled just mentioned about the variability in HbA1c, reflected in the current paradigm of reference ranges for any lab value, the majority of people will probably be on a standard American diet, And with these dietary changes, certain lab values might need to be updated to reflect those dietary changes. The first quote list by Dr. Sean Baker kind of reflects this paradigm where we don't really have a good set of reference ranges for the populations who follow low carbohydrate or a carnivore diet, where they do actually diverge from the general population. And due to the recently hypothesized lipid energy model, some markers that would be normally flagged on a diet might differ between those people in those different diets. So an example of this is actually HbA1c, where any condition that prolongs the life of a red blood cell or is associated with less red blood cell death means that it can be potentially exposed to glucose for longer and be more glycated. This is also a hypothesis of Dr. Beckman. And so because this glycation occurs over time, it really depends on how long the red blood cell lives. And there's a lot of intra and inter-individual variability for the life of a red blood cell.
Yeah, so the main conventional treatments are, well, there are the medications, obviously, very famous metformin, which affects the metabolism and not only like the glucose modulation in the body, but other sides of the metabolism. There are other drugs that work more on the reuptake and other glucose modeling physiologies in the body. From our perspective, ancestralized perspective, it's important to note that managing diabetes with medications can be daunting and potentially hazardous for patients. The medicines may cause side effects and not really solve the root cause of the problem. So we'd rather we'd want people to consider lifestyle approaches and treat the insulin resistance behind all of this. Of course, from the conventional treatments, there are also dietary advices and recommendation, for example, calorie restriction and changing diet quality. Controlling glucose level is something that is universally understood to be useful and helpful. But again, if the diet doesn't really switch and change the metabolism drastically, we might end up having like not efficient resolution of the problem. So yeah, it's important to consider properly the dietary advice because it can even be harmful on the long term.
Yes, thank you, Kaled. So just moving from that, the dietary advice that can be very helpful is the low carb diet. And a lot of our research has found that. We did mention earlier that part of the etiologies for getting type 2 diabetes and prediabetes is being on a high carb diet, often highly processed and low protein. And these kind of high carb diets can lead to spikes in blood sugar levels and insulin resistance over time. So the alternative, a low carb diet approach, will help to reverse that, to start to reduce insulin resistance and create more sensitivity in the different cells around the body and the tissues, and also begin to improve glycemic control. There are 3 types of low carb diet. We've got like a liberal low carb, which is up to 100 grams of carbohydrates per day. A moderate low carb diet will go up to 50 grams of carbohydrates per day. And then the very low carb diet, or a ketogenic diet, often known, is between 0 to 20 grams of carbohydrates per day. The less the carbs you intake, the better your outcomes and the more insulin sensitive you're going to become. And so kind of heading towards or adapting a more ketogenic diet can really improve both insulin resistance and reverse type 2 diabetes and reverse the need for any medication at all. It's also worth noting that our ancestors did not eat high carb, ultra processed foods that we see quite prevalent today, as well as the deterioration in food quality that we're also experiencing since the agricultural revolution. It just, all of it combined is kind of creating this picture of chronic diseases and metabolic syndrome. So it's going back to a more ancestral diet can truly help reverse a lot of the problems we're seeing today. And so just a little bit more information about the low carb diet. So the lower the carbs, especially towards the 0 to 20 grams per day, will switch the body from consuming carbohydrates to starting to burn fat and producing more ketone bodies in the body. This can help to kind of speed up or augment weight loss. And it also starts to lower insulin levels. And as you do that, you begin to decrease the sense of hunger. So this need for constant cravings that we often get with carbohydrates. And studies have shown that the ketogenic diet is it's more superior to kind of achieving more sustained effects on glycemic control and lipid control, and then weight loss over a longer period of time. So in short, we believe that the less carbs, the better.
Great, thank you. So the team graciously threw this fasting slide to me because it's a personal favorite topic of mine, but fasting is very relevant to this conversation. So if we are talking about trying to reduce the need for insulin at the body, at least with regards to our dietary behaviors, then we have very few tools at our disposal, but fasting is a great one. So ultimately, if we want to get insulin levels to be as low as possible, we need the energy balance to be as hospitable towards that as possible, in which case we need glucose to be as low as possible. So there's a myriad of ways that we could accomplish that. Carnivore is often hailed as the ultimate low-carb diet. I would say fasting is another contender for that title. And fasting has also been called a ketogenic, or rather, a ketogenic diet has been called a fasting mimicking diet for that same reason, is that when you're not eating, or if you're not eating carbs specifically, you allow your insulin levels to drop. So different case reports demonstrate the effectiveness of therapeutic fasting to reverse insulin resistance when combined with the ketogenic diet, resulting in cessation of insulin therapy while reducing body weight and maintaining good control of blood sugars. So fasting, I think, has a lot of amazing utility because when paired with a ketogenic diet, like I just read, it has a compounding effect of benefit. Even when you do eat, your insulin levels still remain low. But fasting also is a great gateway into this dietary pattern, because even if somebody is transitioning into a ketogenic diet but is struggling, it's new and foreign, fasting can be implemented immediately. And that's where we start to see concepts like time-restricted feeding, intermittent fasting, these different strategies to help people experience a period of low insulin, low glucose, and can get their body more familiar with processes like ketone production, entering ketosis, and can help expedite the process. So it's very important to refeed while fasting, good quality foods and enough micronutrients and proteins to not suffer from malnutrition side effects. Fasting, I'm very happy, has been growing in popularity, but I still think that there are some misconceptions about how to do it safely and properly. Ideally, of course, you would be speaking with a primary care physician or someone that can help monitor your progress while you go through this. But even for people who are just experimenting themselves, the refeeding process is a part that's often quite neglected when talking about time-restricted feeding. We want to make sure that you've fasted for 12 hours during the day. It's time to eat your next meal. People may be inclined to binge, and especially to binge on comforting foods. So for most people, we're talking about high carbohydrate foods again. If this person is already dealing with prediabetes, type 2 diabetes, their glucagon expression, as Kaled mentioned before, is still going to be elevated. So you would expect to see even higher glucose responses in a refeeding that's very high in carbohydrates than you otherwise would. So that's sort of one step forward, one step back, if not two. A bit counterproductive to what we're dealing with. So refeeding, prioritizing on things that won't stimulate your insulin very much. So we're talking about protein and fat primarily. These are the things, even low glycemic carbohydrates are better. So something like berries as opposed to something like mango. But these refeeding periods, often overlooked, but critical for the therapeutic benefits of fasting, however you integrate it into your diet.
Yeah, from your personal favorite to my personal favorite. So yeah, I'm a big fan of exercise, and I mean, though, as it's written there, though it's not guaranteed to resolve or totally prevent the development of prediabetes and diabetes. There might be even athletes with prediabetes or diabetes, but it's certainly been proven to be very helpful. As we say, like a combination, especially of aerobic and resistance exercise, can help our VO2 max, which is a sign of how well we are burning oxygen, metabolizing. Same with mitochondrial biogenesis. So more mitochondrials, more machinery, and more efficient machinery to metabolize and burn out those extra calories and sugars. Obvious increase in insulin sensitivity, more receptors on the cell, and just if enough resistance exercise is there and enough protein, obviously we get an increase of muscular body mass, which is, let's call it the great sink of glucose in the body. It's like 70% of glucose goes there, so either for usage or storage. So an improvement there will help us remove the glucose and the toxicity of the glucose from the blood. We see a dose-dependent relationship. I really like that term. Possibly the more you do, the better. The lower HbA1c, and that's been studied and shown again and again. What is recommended nowadays is at least 150 minutes per week of moderate intensity aerobic physical activity. So the one that gets the heart pumping and the breathing, short breathing if it's too hard. But especially combined, like we would see the good result if it's combined with at least 2 sessions of resistance training. And that's just general recommendations that can be found and hopefully are not too hard to follow.
All right. Yeah, so big thank you to the team. Certainly they did a lot more heavy lifting on the research and the presentation for all of this. But yeah, that's essentially type 2 diabetes. I do want to wrap it up quickly just with a bit of zoomed out perspective, is that just out of necessity, we address these topics separately, we investigate them separately. That's in part because we are trying to identify the literature that identifies these things specifically, but they all exist on a spectrum. Type 2 diabetes is a manifestation of untreated insulin resistance. Gestational diabetes is the exact same manifestation, just with a different context. Type 1 diabetes, though the cause is different, is manifesting in the same type of symptoms and end results. So we're really attacking the exact same core concept in a number of different directions. So for anyone viewing, thinking that these are two disparate conditions that need to be thought of differently, insulin resistance, the underlying pathology of how that interacts with our lifestyle. If the treatments seem redundant across our different presentations, this is largely why. We're trying to tackle the same root causes, the same environmental factors that are responsible for those root causes, and the same treatments are just going to be effective across all these different diseases. Kaled?
Yeah, extra note, because like insulin resistance is something like that is easier to see as reversible. Diabetes might like really has this name or connotation of something that a patient will struggle to reverse. The switch is on and glucagon and the pancreas is damaged. But we, like as a researcher team, we saw case studies when insulin therapy was removed, some medications, partial reversal, full reversal, or big improvements. And these are the tools, again, to say simple few tools that echo what our ancestors like experienced are really useful, and we've seen it in the case report. So yeah, good luck.
Just to kind of again piggyback on what Khaled said, there you can very quickly get reversal of your symptoms and the disease, and even the need, as he mentioned, that we've seen cases where you've stopped your anti-diabetics. And I think this is just a disclaimer for anyone who is confident and wants to start on these low carb ketogenic diets. If you are on these kind of medication and you go to switch to a low carb, it's likely that you're going to get a quick kind of results, and your need for those medication will reduce quite significantly. So just for people to also be aware that actually the doses that you're on will reduce, and to kind of make sure that you're monitoring your blood sugars and talking to your health providers, and to hopefully be able to come off these medication altogether. So just for a safety point of view. Yeah.
Absolutely. Yeah, thank you. Everything here is accessible and should be available to you all, but please make sure you're doing so responsibly. But yeah, thank you all for your time, and we'll see you in the next video. Bye.